Dear colleagues and dear friends, my talk will be made quite easy because the content of the anterior cranial fossa is quite simple. We have brain, we have bone, and we have one cranial pair, which is, of course, the first one and the olfactory nerve, as you know. So my talk will be essentially focused on the workup of olfactory disturbances. I'll just look how to manage this complex equipment. Okay. The anatomy of the olfactory tract is quite easy. We have olfactory bulbs, which are located within the olfactory grooves, appearing as hypointense structures on these T2 weighted coronal images. T2 weighting and coronal incidence is, of course, the reference for the olfactory tract because we have a good display of both sides and we have an excellent contrast on T2 weighting. Below the olfactory bulbs, which are the extremity of the olfactory tract, anterior extremity, of course, we have the cribriform plate of ethmoid. I will talk about it a little bit later. And above them, we have the gyrus rectus on the midline, the olfactory sulci separating the gyrus rectus from the medial orbital gyrus. Okay? We step a little bit backwards, and more posteriorly, the olfactory tract becomes smaller. We have the olfactory nerves here, which are quite smaller and have a lower caliber than the bulbs, which are enlarged. And here on this coronal reformat, on this axial transverse volumetric reformat on T2 weighted, we also recognize the bulbs, the olfactory nerve, and the olfactory nerve splits into three striae, as I will show later. One important aspect, one important concept is that the olfactory bulb receive unmyelinated axons which are crossing the holes, the micro holes of the lamina, the cribriform plate of the ethmoid, and the olfactory information runs from the neuroepithelium, olfactory neuroepithelium at the ceiling of the fossal nasa, through the endocranium, through the lamina cribria, as illustrated here. On this Sagittary format, we identify the olfactory fascicles or olfactory cilia, which are those unmyelinated axons, which are reaching the olfactory bulb, olfactory nerve, and the next step is that the olfactory nerve splits into three olfactory striae, medial, intermediate, and lateral. And thereafter, the most important stria, which is the lateral one, is directly projecting on the ipsilateral mesio-temporal area, mainly periamygdaloid cortex and entorhinal cortex. And it must be highlighted that those cortical areas are made of paleocortex. Thus far, the olfactory tract projects on the old brain, the phylogenetically old brain, the brain of the primitive man. This is a unique characteristic of olfaction that it projects on the old brain. There are also projection on the neocortical area here, the orbitofrontal area. Thus, we have a kind of bivalence of the projection of the olfactory system on both paleocortex and neocortex. It is quite interesting in the development of the human being because, as you see, this good friend of mine, the man of Neanderthal, had a small forehead, a small neo-brain, and a primitive brain, but he also had a great nose and certainly very performing olfactory capabilities. Another interesting characteristic of the olfactory tract is that it is closely linked to the so-called limbic lobe or limbic system through the lateral olfactory striae projecting on amygdala and hippocampus. Thus far, the olfaction is the privileged sensory modality influencing the limbic system, which is, as you know, the place where emotion, instinctive reaction occur. A last characteristic I have to mention is that the areas where olfactory tract projects are not specialized in the processing of olfaction. As you know, we see with our calcarine cortex, this is highly specialized cortical area. We see with the calcarine area, we hear with temporal area, and we smell with those area, but those area are doing other processing, other processes than olfactory information. Aside MR, which is of course the best suited imaging modality in the purpose of workup of olfactory disturbance, you have other modalities that can give relevant information. On the upper row, you see CBCT, cone beam CT images, which gave relevant information regarding bone, of course, and we easily identify the olfactory grooves where the bulbs and the olfactory nerve is crossing, but we don't see it, of course. We see on the sagittal ray format, we see the micro holes of the cribriform plate of ethmoid. And on the coronal ray format, we very well see also the olfactory grooves. This X-ray methods give information about bone. This is not a surprise. If you are looking at bone information, you will use CT modality, but of course MRI will be preferred because of higher and best soft tissue contrast. Using conventional MSCT, you have additional information. With cone beam CT, you have absolutely no information about soft tissue. With conventional CT, you have some additional information about soft tissue, like represented in this case. You see that this patient had traumatic anosmia. He didn't want to undergo MRI because he was claustrophobic, and instead of performing MRI, we were constrained to perform a CT. And you see that there was contusion, there were sequelae of contusion, but also there was, it's a little bit limit, of course, there was also an atrophy of the left bulb. Of course, we should have preferred MRI to see it. 3T or less, we made some experimentation on a few numbers of volunteers, and we didn't find significant differences in information about size and shape of olfactory tract, so that we use indifferently 1.5 or 3 Tesla. It is not mandatory for us to use a 3T system to investigate the olfactory system. And now we are coming to the pathological side, the first category of pathology is the congenital disturbance, which are linked to dysgenesis or anagenesis of the olfactory tract. And as you know, in the Kalman syndrome, it is associated with hypogonadotrophic hypogonadism. This is a very interesting and exemplative case because you had a normal olfactory sulcus on the right side. You had no olfactory sulcus on the left side, and you had no olfactory tract. But there was a small structure which could have been interpreted as a small bulb, but it was not. On the 3D reformat, you see that this structure was in fact a small artery crossing in the olfactory groove and not an olfactory tractus. There was complete bilateral agenesis of the olfactory tract in spite of the presence of an olfactory sulcus on the right side. Congenital disease is not so simple as yes or no for the presence of an olfactory tract. In this interesting case, you see that in the most anterior plane, slice location, you had no sulcus on the left, you had a sulcus on the right. You should say, okay, right side is normal, but left is not. A little bit backwards, you see that the olfactory bulb is appearing, which is not a surprise. But on the other side, you have a black, unidentified object. What is it? We step again a little bit backwards, and we see that the black object disappears, and we see the appearance of a normal sulcus and the beginning of the bulb. And on the last, most posterior image, you see that you have normal bulbs on both sides and normal olfactory sulcus. And what is very interesting is that what was the black object? It was unidentified. We did contrast-enhanced images with FATSAT, but we had no peculiar information. And what gave the information was, of course, the CT. It was a little osteoma which was located in the olfactory groove. And this is interesting because developmentally, this osteoma had retroponed the olfactory bulb, which was more posteriorly located on the left side. But this patient, in spite of having normal sulci bilaterally, complained from left-sided hyposmia. The most frequent, we are leaving the congenital pathology. We begin the acquired olfactory disturbances by the most common one, which is the mucosal olfactory disorder. It is obvious that it is needed that odorant molecule we are inhalating must be able to reach the olfactory neuroepithelium to give smell, of course. In normal condition, the olfactory cleft, thus the ceiling of the nasal fossa, are free. When there is a mucosal thickening or mucus or both, you have an occlusion of the olfactory cleft and you have mechanical obstacle to the odorant molecules. We can no more reach the olfactory epithelium, and in this condition, it's obvious that there is a problem of smelling. In some condition, it's very caricatural, it's very extensive, like in this case of adenomatoid hamartoma. In other conditions, you I think we must be careful when interpreting small mucus deposits on the olfactory cleft, and we always need to consider that the physician, by making a flexible endoscopy, has the last word. Another category of pathology is the post-infectious olfactory dysfunction, which is the extension of inflammation of the mucosa, of viral inflammation of the mucosa through the myelinated axon to the bulbs, giving what we can call a bulbitis and a secondary scarring and destruction of the bulb. Here you have normal-sized bulbs in a person who had no problem. Here we have post-bulbitis, asymmetric atrophy, as you see. The right side is very thin, the left side is a little bit less thin, and in this case we have bilateral severe atrophy. This highlights the value of measuring the olfactory bulb volume. I will indicate you why in a few minutes, by the time is crossing. The third category of pathology is post-traumatic anosmia. Okay, you have two main mechanisms for giving olfactory disturbance. The first one, which is well known, is the shearing injury of the filia olfactoria at the cribriform plate of the ethmoid, and the second is the cortical damage, traumatic damage to the olfactory area of projection. Here you have a coronal T2 image in a case of post-traumatic anosmia. You will see that the right side is abnormal. You have abnormal signal intensity within the right bulb, a kind of bulbomalacia, we should say. On the left side, you have an abnormal conformation of the bulb, which is also atretic, and you have small hemosiderin deposits and gliotic scarring on the gyrus rectus here. Observe that FSA flare image in a similar slice location is almost completely falsely negative. This is important. I think that coronal T2 fast spin echo standard is really the reference for imaging the bulbs. A very nice case in which you have hypersignal intensity within the bulbs, this bulbomalacia 2, and you have a thin line surrounding the atretic bulbs, which is a linear deposit of hemosiderin within the pia of the bulb. You have, again, scars and hemosiderin deposits, and you see a sagittal view of the bulb with hypersignal intensity and a margin of hyposignal intensity. Tumors. Well, there is a specific tumor of the olfactory tract, which is the esthesioneuroblastoma. This is a very rare condition with two peaks in frequency, the first one in pediatric age, the second one around 50 years. This has no specific characteristic except maybe the location with an epicenter on the base of the skull at the level of the cribriform plate and an extension both upward and downward. But of course the diagnosis is a biopsic one, and when considering the few patients I have seen with this malignancy, with huge tumors, I don't think that olfactory disturbance was very discriminant in those cases, because they came with intracranial hypertension, bleeding of the nose from the nose and so on, but they had not been alerted by loss of smell. At the other extremity of the scale of severity, you have another paradigmatic condition, which is the neoplasm, which is the meningioma of the olfactory groove, a well-known pathology. And this is very interesting. This meningioma was impinging and thereafter completely encasing the left olfactory bulb. And this is very interesting because this patient, who was a fireman, I talked with him, had the only complaint of monolateral left-sided loss of smell. This was a clinical confirmation, that projection of olfactory information is ipsilateral and monolateral. Okay, there are many destructive disorders which are impinging of the olfactory tract. This is evident. You have inflammation, like in this case of Wegener's disease, with bone destruction and granulomatous tissue encasing the olfactory tract. You have local primary malignancies, like this case of ethmoid carcinoma. There are other neoplasm, squamous cell carcinoma, sinonasal undifferentiated carcinoma, accessory salivary gland carcinoma, lymphoma, and so on. The list is not exhaustive. And of course, you have carcinomatose, you have meningeal spread of neoplasm, here a case of neoplasm of the breast with a complete encasement of the olfactory bulbs too. Quickly, because I have not so much time, many neurodegenerative disorders have a olfactory component in the clinical presentation. Alzheimer, Huntington, Parkinson, Down, again, the list is not exhaustive. We are performing a huge clinical research about Alzheimer's disease because a vast number of patients have olfactory disturbance, and we have the impression that olfactory disturbance could precede the classical memory disorders in those patients. There are many iatrogenic conditions which impairs with olfaction. It's obvious, local surgery, local radiation therapy, and many drugs, not exhaustive list again, with local antibiotic, inhibitors of the ACE, antiblastic drugs, and so on. Of course, tobacco smoking should not be allowed, this is evident, not only to avoid some forms of lung cancer, but also because tobacco smoking lessens the olfactory capabilities. But abstinence of tobacco is always rewarded because olfactory function recovers after stopping smoking. I have few time to talk about quantitative measurement. We have seen a case of Kalman disease with an olfactory sulcus absent on one side and present on the other side. We have made a study in in person suffering from congenital anosmia, and we found that if the clinical question is, has this patient congenital anosmia? It's not very clear in many cases. Do you have smelled normally in past time? I don't know, maybe, and so on. But it's imprecise. And if you measure on this manner the depth of the olfactory sulcus, you can, and if you measure 8 millimeters, you can exclude a congenital anosmia with a sensitivity of 72 and a specificity of 100. Just measure the bulb. If the patient is suspect of having congenital anosmia, you have a precious indicator by measuring the sulcus. Another important aspect is the measurement of the volume of the bulbs. Okay, we use a planimetric contouring technique. You contour the bulbs on all slides. You have a surface in millimeters square. You multiply by the slice thickness and the interslice gap, and you have a volume. And which is interesting is that there is a close correlation between the olfactory bulb, the volume of the olfactory bulb, and the olfactory performance. As illustrated here, we all have a peak of performance at the age of 40. This is given by this curve comparing TDI score, which is a clinical score of smell, to the years of age. And look at this, you have olfactory volume against the age, and you have almost a similar curve, which means that there is very, very close correlation between the performance of smelling and the volume of the bulb. And this is of major interest in the clinical practice, of course, because if the patient does no more smell after influenza or coryza and so on, and if you document small bulbs, hope for recovering normal function is almost lost. Okay? In this plot graph, you see that post-infectious in anosmia, you had an interesting strong correlation. P was very well, R was not so well because of cloud was a little bit large, but you have a correlation between the olfactory bulb volume and the TDI score, which means the clinical score of olfaction. Okay, I think I have no more time to speak to you about the psychophysical testing of olfaction. I will just say the anosmic patient will undergo testing, sniff test, okay, to assess the severity of the disorder, but these testings have no specificity. Whatever the etiology, you have no indication about whatever the value of the deficit, you have no indication of the origin. And this is why imaging is very, very important. As radiologists, we are key. We have the key. We have an important key of the diagnosis of the origin of the anosmia. Okay, we can perform bold fMRI. You see here, it needs expensive material, but it runs. You see it here. We can perform DTI tractography. It doesn't run very well. And that's my conclusion. Sorry for the little delay. The ENT physician assesses and quantifies the olfactory impairment. The radiologist indicates as much as possible the origin of the trouble with measurement of the olfactory sulcus and olfactory bulb volume, and advanced imaging techniques should give insights into the physiology and circuitry of olfaction. I thank you for your attention and sorry for the little delay.